PTH therapy in the impaired PTH effect. I'll start with some of the pathophysiology. As we all know that PTH acts mainly on the three organs of our body: kidney, bone, and the gut. In the kidney, it increases the 1-alpha hydroxylase activity in the proximal tubule, causing increased level of calcitriol, which increases calcium and phosphorus absorption from the gut. As well as in the distal tubule, the PTH increases the TRPV mediated calcium absorption and reduces the risk of nephrocalcinosis. And there is an increased excretion of phosphate or the phosphatidic effect of the PTH by inhibiting the NPT2 channels in kidney. As well, in the calcium deficit state, it increases the bone turnover, bone resorption, increasing rank ligand and decreasing the osteoprotogenin, and increases calcium and phosphate level in the blood. So the net effect here is the increase in the serum calcium level, decrease in the serum phosphorus, and decrease in the calcium excretion via kidney. In any effect by where there is impaired PTH effect due to the hypoparathyroidism or activating mutation of the calcium sensing receptor or APS, these effects will not be seen, leading to a scenario of hypocalcemia, hyperphosphatemia, and hypercalciuria, leading to nephrocalcinosis. Now, why we are bothered about this hypoparathyroidism and intended to use another therapy instead of having this conventional therapy? So the major difference from the adult hypoparathyroidism in case of children they were much more symptomatic in comparison to the adults due to the high skeletal requirements of the calcium and requiring multiple hospital admission due to hypocalcemic episodes. Not only that, they are much more prone to develop complications in terms of extracellular calcifications like basal ganglia calcification, renal calcification, leading to nephrocalcinosis and renal dysfunction, and a low bone turnover state. So what we have in our hand, the two treatment modality. One is a conventional modality that Sarah has already talked about. It is easily available, cheap, easy to administer by using high dose of calcium tablets and active vitamin D analog in terms of calcitriol. But we sometimes require this PTH therapy. Why? We'll discuss about this in the subsequent slides. So what the conventional therapies target? Our target will be there will be a low normal serum calcium around 8.5 to 9, and there should be avoidance of the hypercalciuria. Also, there should be avoidance of the important symptoms leading to a increased quality of life. This conventional therapies has some disadvantages which made further think about the replacement therapy in terms of PTH. There are need for some additional therapy in terms of thiazides to decrease the nephrocalcinosis or urinary calcium excretion. We can use the phosphate binders like sevelamer. There is an increased risk of renal dysfunction in case of conventional therapy that I'll discuss in the subsequent slide, and that will lead to renal dysfunction in the children. Also, there are increased risk of ectopic calcification that leads to extrapyramidal symptoms, cataract. Metabolic bone abnormalities still persist on the conventional therapy, and it impairs the quality of life, and some children still persist bone pain even on the conventional therapy. So this study was done in 2015, where in USA, where it was been shown that on conventional therapy, there were 29 children in this study, and the mean duration of study was around 7.5 plus minus 5 years. They had shown that there is an increased risk of nephrocalcinosis in these children around 38%. And the most interestingly, around this 38%, only 2 patients were getting resolved. Rest of the person were showing the progression of this nephrocalcinosis in the further study. Also, they had shown that there is a decreased EGFR in these children from between the 60 to 90 in almost half of these children. They had concluded that this decrease in the GFR, though not significant below 60, still may persist further and may cause renal dysfunction in the future. So these things have led our mind to think that whether we can use another therapy in terms of PTH therapy in the children, which has been already used in case of adults. So what are the preparations we have right now in our hand? Number one is teriparatide, that is 134 molecule of the recombinant PTH that is already FDA approved for the adult osteoporosis around 2002. There is a full length recombinant PTH that is 184 that is also available. There are two other molecules. One is the abaloparatide, that is a synthetic analog of PTH related peptide, FDA approved for osteoporosis. And recently, a palopectiratide, a molecule that is FDA approved for the adult hypoparathyroidism. Right now, in our hand, there is no guidelines for the PTH therapy in children, and no FDA approval for any molecule at present is present. So there are some case reports. There are some small RCTs that has been done by using this PTH therapy in children. And first was done by Dr. Fuller Albert and his Ellsworth in John Hopkins Hospital, Baltimore, back in 1928, where they have used PTH extract on a children with hypoparathyroidism, and they have shown a significant effect in terms of increase in the serum calcium, decrease in the serum phosphorus, as well as increased phosphorus excretion. But the recombinant PTH comes much later, around 1972, and the use in children has been started around 2005 or 2006. So what the questions do we have in our mind before using this recombinant PTH therapy? First question is, which age group we can be used? Can it be used in very infancy or very neonatal age group? Whether this conventional therapy versus this PTH therapy, whether it has a better beneficial effect in terms of nephrocalcinosis or renal dysfunction. How long this therapy can be used, considering the black box warning of the FDA, they had told that there is an increased risk of osteosarcoma in case of children. So how long we can use? We all know that in adult osteoporosis, we can use around 24 months or something like that. So what would be the physiological therapy? What would be the physiological regime should be used in case of children, whether it should be once daily or twice daily, or there should be a continuous infusion, and what would be the appropriate dose in case of children, and which one would be the better? It is the 134 or it is 184, which would be the better one PTH in terms of children. Whether we can use it in syndromic PTH, and what are the safety issues are the another questions that we have in our mind. So we'll come one by one. First, this is a case report around 2006 in USA by Dr. Mittelman and his group. He has taken a 3-week-old boy with activating calcium sensing receptor mutation and given teriparatide. Though the teriparatide was given much later, around 14 month in this child, they had come to a conclusion that there are decreased episodes of symptomatic hypo and hypercalcemia in these children, as well as they had shown that there is a decrease in the urinary calcium excretion using this recombinant PTH, which further improved his quality of life and decreases the further complication. In the subsequent year, 2007, there has been a case report where a 17-day-old boy with idiopathic HPT who presented initially with calcium level of around 4.5 was refractory to the conventional treatment. There was multiple boluses of calcium infusion was given, but calcium could not be elevated much more than 6.9. But a single dose of teriparatide in this child raised the calcium level from 6.9 to 9.3. So they had concluded we have used this therapy to increase the calcium levels faster and more safely than any other commonly methods.
After stopping it, maintained.
They didn't comment after whether they had maintained or not, but they just that said that it is a brisk action, then it increases the level, but the child was refractory to the conventional treatment and regarding that.
Because this is not unusual. Many times as I discuss, the requirement may be very high. So this could be a good indication. You give a single dose or something, and then you can build it up, and then you can maybe stop it.
Yes. Now the next question, whether the conventional was better or the PTH therapy, which one is the better therapy? So this is a case, this is a randomized control trial that has been done by Dr. Winners and his group in 2010, taking 12 children of 5 to 14 years with chronic hypoparathyroidism. They had given PTH teriparatide in them for 3 years, but they had concluded that there was no substantial benefit in case of maintaining normal serum calcium, urine calcium, kidney function, as well as bone functions. It was probably the first study where this conventional method was compared to PTH therapy. But they had raised some questions in this study. This study showed that there was an increased bone turnover, and there is an increased bone formation markers like osteocalcin in this group of children. So considering the risk factor of osteosarcoma, they said that whether we can use this in a long-term basis, whether there is any role of any 184, that is a full length recombinant PTH, whether this is safe for the children. So a study in 2009 by Dr. Thiemann and his group had shown that a 6-year, 2-month-old girl with activating calcium sensing receptor mutation, they had treated for around 14 years. And they had concluded that this long duration of PTH therapy in this child didn't show any risk of any osteosarcoma or any bone malignancies in this child. Subsequent to that, what was the regimen that should be used, single dose or the twice daily? Here also in 2008, the winners group had done a study on the children. Previous to this study, they had studied on adult population, showing that twice daily regimen is better for the adults in comparison to the once daily. In the children group of 14 children around 4 to 17 years old, the treatment duration was 14 weeks. And they concluded that twice daily regimen, as described in case of adults, was much better than the once daily regimen. Not only that, they had raised the question whether we can give it to the thrice daily or a continuous infusion of PTH like we use in cases of insulin therapy, basal therapy in type 1 diabetes. Now, subsequent to that, so there is a concept there whether we can use this continuous infusion of PTH, and what is the beneficial effects of continuous PTH therapy over the twice daily or thrice daily regimen. This was a study that has been done by Dr. Lingard in 2011, where he has taken 3 boys, of 2 having APS and 1 having idiopathic HPT. They had initially started the child on the conventional therapy and 184 PTH, but there was a discrepancy of calcium and phosphorus level. The levels are not very smooth, they are fluctuating levels. So they have taken the Paradigm 515 Medtronic insulin pump as a delivery device for the PTH therapy and given for at least 3 years. They had come to some conclusions. There is a long-term benefit, there is a long-term stabilization of the serum calcium as well as urinary calcium level in this study. Also, they had said that during this acute fluctuations of the calcium during the illness, dehydration, there is a better control of the calcium level, leading to further decrease in the hypocalcemic episodes in this study. But they have given a warning that we should not use in every children with hypoparathyoridism. We should be much more cautious in terms of using this PTH therapy.
What do you think, like if you talk about replacement therapies and endocrinology, we have got, most commonly we use it for insulin in type 1 diabetes. We use growth hormone in growth hormone deficiency, pyroxine and PTH. So if you compare all this, which one of these will be the most challenging?
In my opinion, the most challenging will be growth hormone will be the much more, calcium PTH therapy would be much more challenging.
Growth hormone will be easy because you are giving growth hormone.
But sir, there is monitoring will be some bit of.
You can monitor using IGF also. If you talk about thyroxine, you give once a day, it's stable. Growth hormone level, if it goes up also, it's not going to do a problem. If your insulin goes up or down, you have problems. But I think PTH will be even more difficult because PTH is very exquisitively controlled. As soon as your calcium goes down, PTH goes up. So otherwise, if you give a once daily injection, that's what I'm trying to say, that in diabetes we talk about basal bolus versus mixed plate versus pump. So I think this will even be more better to give a physiological regime. Because if you give one injection for 24 hours, it is not going to do justice. You will have persistently high level of PTH. So that is the challenge which is happening with once daily injection.
Yes. Now in 2023, there was a study by Dr. Lindsay Mart and his group, and they had taken a 14-year-old girl child with APS AIR mutation positive. They had similarly used 184 therapy as well as continuous infusion of PTH therapy by using a Omnipod. Now they had come to the conclusion that the PTH continuous delivery was much more better in terms, and probably it may cause the decreased need for conventional therapy, and it is much more better than the 184 therapy. One additional benefit they had shown in this study that we can modulate the frequent changes of the PTH level in this study so that acute hypocalcemic episodes will be decreased. And in cases of high requirements, like in case of GI illnesses, dehydration, we can also modulate this therapy to get a better control of the calcium level in our body. In 2020, a similar kind of study was done here by Dr. Laurer, who had shown that a 5-year girl with APS1, they had proven that the RT-PTH 184 regimen was much more better in terms of patient comfort and family adherence. What happened there? Initially, the patient was put on the RT-PTH therapy, but the only issue patient had that he had to carry this insulin pump all the time with him or her. And this has changed the mind, and after giving consent, they had changed to RT-PTH therapy, which was almost similar or far better than in case of infusion therapy of RT-PTH 134. Also, we can use there are some case reports where we can use this PTH therapy in syndromic hypoparathyroidism. So what are the safety issues that we had still now in our we have there is one risk of osteosarcoma that has been FDA black box warning till now. But all the studies that has been shown in osteosarcoma after using PTH is done on a mouse model, and it has been shown that this mouse model has a different bone metabolism from the us. All the primate study till now has been done has shown no evidence of any osteosarcoma in the primates. Also, the doses that has been causing this osteosarcoma in that rats were much more higher, almost 15 to 20 times higher than that we use in our in today's perspective. Also, there was no very long-term studies and very long-term follow-up in children, though the post-marketing surveillance of FOTIO of 15 years using RT-PTH 134 and 10 years of 184 shown no evidence of osteosarcoma in the children. This is a case study that has been done for 10 years in children with hypoparathyroidism with APS1 or calcium sensing receptor, and there was no risk showing any osteosarcoma or increased risk of any osteosarcoma in these children. Now, so what are the issues do we have over the conventional therapy? So all of the studies that we have right now in our hand are not very long-term studies. They have small population, and there are very limited RCTs to prove the efficacy of this RT-PTH. There is no data till now available which is showing that it has a greater efficacy than the conventional therapy. And in a developing country like India, there is a cost issue of teriparatide to also be there. Also, there is very less safety profile, and the most important challenging factor would be in case of infusion of the PTH would be development of a calcium sensing sensor that is right now not available in our setting. So what could be our take-home message? There's PTH therapy.
So
right.
What would you recommend? Which kind of indication you will recommend?
Gathering all the evidences and what we have in our hand right now, I think the refractory cases of hypoparathyroidism and the calcium sensing receptor activity mutation or APS mutation,
Predominantly in the acute phase of management, and calcium sensing receptor definitely. This could be something which is going to be quite helpful on that regard. However, nearly all the data is coming from the NIH group.
Yes.
They have done the maximum studies other than just sporadic case reports. So it's a place to watch. Adults, how often are they using it?
In case of hypoparathyroidism, sir, it is not FDA approved yet. In case of teriparatide, it's not FDA approved.
So, if at all it is required, it's more in children because the management is more difficult in children. So, but there's a catch-22 situation.
Yes. So that's all. Thank you.
Okay. Thank you, Alappan, for a very good talk. You really summarized it very well. The key message basically here is that PTH is a new drug which has options in terms of management, but just because it's new doesn't mean that we should stop the other treatment. Now, if you compare this to another agent like brosumab, which is a monoclonal antibody to FGF23, how do you think both compare? Like which one you will be ready to accept right away and which you will be having a bit of a concern.
Also, more, I would say, stable agent than the PTH, and it has more therapeutic benefits. Like lots of studies have been done, like in the if we see.
So if you forget about the study, if you think of concept also.
The phosphate levels.
So what it is doing, it is taking out a bad thing from the body. So that will never be going to be bad for you. While here you are actually giving something which is bioactive. So borosumab is not bioactive. It's a way of sequestrating things out of that. So it's not going to be that much harmful anyway. But here you're dealing with an agent which, if being given at a high dose, will cause hypercalcemia, will cause bone problems. So of course, you are always better in terms of sequestrating agents as compared to an active agent. So this is a basic concept difference there. So we need to work out, and often we are able to manage very well in terms of PTH. So there are a few questions which are